Committee on Health Care Reform will now come to order. The clerk will call the roll.
Chair Harless.
Here.
Vice Chair Howard.
Here.
Representative Wally. Representative Price.
Here.
Representative Bonin. Representative Rose.
Here.
Representative Frank.
Here.
Representative Click.
Here.
Representative Oliverson.
Here.
Representative Busey.
Here.
Coming.
Representative Morales. Representative Bonin.
A quorum is present. As a reminder, anyone present wishing to testify before the committee, please register at the kiosk located in the hallway behind the hearing rooms. If you require assistance in registering or testifying, please contact our committee staff. We have Greer Gregory to my right and Jack George up here in the front. To accommodate all those who wish to testify, there will be a time limit of 3 minutes per witness during public testimony. You ready to go? Okay. The chair lays out House Bill 2556 and recognizes Chairman Oliverson to explain his bill.
Thank you, Mr. Chairman and committee members. I appreciate the opportunity to discuss what I think is a very exciting idea. As you all know, we have a tremendous workforce shortage in healthcare, particularly in the area of nursing, but also in the area of advanced practice folks that would be physicians or other mid-level practitioners. The reality is that everybody who can work in this field that under the current mechanisms that we have is already in the workforce. There is, however, one supply of individuals that's currently on the bench, unable to do anything in healthcare despite having a doctorate degree in medicine and advanced training. Because they're currently unlicensed, they're unable to do anything other than work as lab techs or surgical assistants, and that is physician graduates. These are individuals who completed a 4-year medical school program, earned a doctorate in medicine, but because of the, I would argue, arcane and very high-pressure, frustrating system that we have in this country, which is the match, they find themselves in a situation where less than 3 months before graduation, they have no place to go. And at that point, they either have two options. They can either scramble into a fairly meaningless program that they did not want to do, did not contemplate, often is a 1-year training program with no guarantee of an opportunity to actually complete a residency or be in a position to have any board certification of any kind, but essentially be at the beck and call of a hospital system that is essentially using them almost as indentured servants for that first year and then casting them aside. Or they can graduate and get a job working at Starbucks, or they can work somewhere else, but they'll never be able to use the advanced medical knowledge and training that they received in medical school. So what House Bill 2556 would do is it would create a pathway whereby the medical board, under its promulgation of rules and discretion and using its judgment, could adopt an associate physician license, which would allow these doctors with advanced medical training to be able to practice under the direct supervision of a licensed physician. This would be essentially a permanent pathway for those that were interested. I want to be clear about a couple of things. This is not a pathway to full licensure. It is not a substitute for a residency, and it does not guarantee board certification in any specialty. It is simply an alternative to the current system of dead ends that most of these doctors find themselves in, and it gives them an opportunity to get out into the workforce and earn a respectable income, pay back the student loans that they have, which are outstanding, and gives them some time to either decide, A, is this what I want to do for the rest of my life, or B, maybe I chose the wrong specialty, maybe I aimed in a direction that I wasn't destined for, and maybe there's something else out there. Maybe instead of neurosurgery, I want to be a primary care doctor. But these are decisions, and I can speak from personal experience as a doctor who went through a process where I didn't match into what I wanted to do. And 6 weeks is not an adequate amount of time to completely reorganize your life when you've spent the last 3 years moving towards a certain direction only to have that pulled out from underneath you at the last possible second. And so this would give those folks a chance to think this through, figure out what they wanted to do, pay back some of their debt, earn some money, learn about a new opportunity, see if that's maybe the direction they want to go, and at the same time provide a very high level, a high standard of care to people in Texas who are lacking access to care because of a lack of health care providers. In addition to that, well, let me just say that in order to qualify for this license, you would have to have passed both Step 1 and Step 2 of the licensing exam. And that gives us, in addition to the fact that they have an advanced medical degree, a doctorate, this gives us certainty that they actually have the minimum basic knowledge to be safely practicing out in the world under the supervision of another doctor, much like a nurse practitioner or a PA or other type of provider in that space, essentially a similar type of arrangement. There also is a second group that this bill contemplates as well, and that is that there are folks who've trained outside the United States who can never be board certified and practice under the current schema of getting a medical license because their pathway of training is not recognized because it wasn't done here. It's not recognized as being equivalent to here. But there are folks who have trained outside the United States who have practiced, some of them for more than a decade, in primary care or specialties that also have advanced medical knowledge who could come to the Texas and could work under the same licensing arrangement, the same supervisory arrangement, and augment our care workforce. As an example, I have several friends that I work with in my own practice who are board-certified obstetricians from countries in Central America. One is from Guatemala and others from El Salvador. They're working basically with an OB-GYN right now, and they just close the skin at the end of the case, despite the fact that they have a decade of experience in practicing medicine, practicing obstetrics, speaking multiple languages. They are completely unable to use their knowledge and training. So this pathway would also exist for those folks to get this limited license, provided that they could pass the same licensing exams that we have here in the United States to prove that, in fact, their medical training that they received elsewhere is equivalent to the medical training that we have here in the United States. I am working on a technical cleanup. We will have a substitute for you members. I don't have it today. It basically is some technical changes. I've been working with the medical board on this. They are here today. They are excited about this program. They believe that this is something they can clearly do. There are probably in the neighborhood of about 7,000 unmatched medical graduates every year. I don't know how many foreign medical graduates would apply for a program like this, but right now there is one state that allows this. There are 8 other states that are contemplating similar legislation. So the possibility is that we could have a fair number of folks that would want to come to Texas and take advantage of this program. I also want to say one quick thing, because I know this has come up. People have asked me, how would these folks be able to bill for their services? And the reality is that as from what I have been able to gather and learn, because they're not recognized as a provider type by CMS, they would not be able to bill CMS, Medicare, Medicaid for their services. They would have to bill under the other physician's license who's supervising them, which actually I don't really think is a problem, because it actually creates a better chain of accountability and supervision and making sure that these folks, as they're practicing, actually have an adequate level of supervision. And I would just tell you, as a former medical student myself, that this is what you do your fourth year of medical school. You're basically working under the direct supervision of another physician. You're seeing patients, you're doing histories and physicals, you're prescribing medications, you're rounding on patients, you're discharging them from the hospitals. These are all the functions that they would likely be performing out there with the associate physician license. They spent their entire last year of medical school doing exactly that as a practicum, which is equivalent or better than most of the other pathways of a similar nature as far as having that full year of sort of doing what it is that you're going to do out there in various clinics and things and working with physicians. So that's what it does. I literally think this is just the lowest of the low-hanging fruit as far as addressing our workforce shortage. These folks are already trained. They're already there. Some of them are baristas that fill your coffee when you go to Starbucks because that's the only job they can get right now, despite having a doctorate and owing $200,000 in medical and student loans. And this gives them a chance to be part of our Texas workforce. With that, I'll take any questions. I'd like to reserve my right to close.
You'll certainly get that. Let the chair recognize Representative Wally and Representative Morales as being present. Members, are there any questions for Chairman Oliverson? If not, we'll proceed to testimony. Right now, the chair calls up Kevin DeRatna. Hi, Kevin. We show you as Kevin DeRatna, Chief Strategist at the Heritage Foundation, testifying on behalf of them and yourself and testifying neutral. Is that correct?
That is correct, sir.
Thank you. Please proceed.
Okay. Thank you, Mr. Chairman. Thank you, Representative Oliverson and members of the committee for being here. My name is Kevin DeRatna. I'm the Chief Statistician, Data Scientist, and Senior Research Fellow at the Heritage Foundation, Washington, D.C. The views I express in this testimony are my own and should not be construed as representing any official views of the Heritage Foundation. I am testifying on HB 2556 and in favor of addressing the physician shortage in Texas by using an untapped resource. I have PowerPoint slides that are printed out for the members, and you are welcome to follow them with me. This work is based on a paper that I published with David Balot and John O'Shea at the Texas Public Policy Foundation. That was also distributed to all of you. So the question is, and Representative Oliverson began to touch on these things, they're important questions to ask regarding health care. Namely, what are the barriers inhibiting access to care, and is this issue being approached from the correct angle? So on page 3 of my slides, we define access to care. It has been defined by the Institute of Medicine as having the timely use of personal health services to achieve the best health outcomes. So how can access be improved? There's the supply side and the demand side of the equation. Much of healthcare reform in this country has been heavily focused on the demand side in terms of improving access, such as in terms of health insurance. One of the most well-known reforms was the Patient Protection and Affordable Care Act, commonly known as Obamacare. Not nearly enough has been done on the supply side of healthcare, however. And medicine, next page, medicine has evolved into a highly regulated field. And there are significant questions about licensure regarding physicians, nurses, and physician assistants, as well as many other medical personnel. But my colleague Paul Larkin has talked about how licensure in general, occupational licensure, is one of the nation's largest forms of regulation. And the question is, could we reform occupational licensure in this field to improve access to care? So we're going to focus specifically on medical licensure here. How does one become a licensed doctor in America? This is page 5 of the slides. You firstly have to graduate from an accredited medical school, and then you have to complete your residency. And after completing the residency, you can obtain your licensure and certification. This is how most doctors in this country have obtained their licensure and subsequently their certification in their specialty of interest. The next page. What is a residency? It is essentially a post-medical school internship / apprenticeship training. these residency programs are accredited by the nonprofit ACGME, the Accreditation Council of Graduate Medical Education. And these are generally 3 to 7 year training programs depending on the specialty, from internal medicine and pediatrics to around 3 years, to fields such as neurosurgery, which would take significantly longer. They are heavily subsidized by taxpayer funding from entities such as Medicare, Medicaid, the HRSA, and the VA. And after you complete your residency, people seek to obtain their license, as well as they are now board eligible to sit for the board, the specialty board in their field, such as internal medicine, emergency medicine, and so forth. So this is where the supply of physicians in this country comes from the residencies. So page 7 of the slides, I asked this question: what does the supply of doctors in this country look like right now? And on page 8, we get into this question specifically for Texas. The AAMC has forecasted a significant shortage by 2030. And there are 2 reasons for this. The patient population, America is aging, and this has manifestations in many other policy areas as well, including Social Security and Medicare. And the medical profession, many of these doctors are retiring. So as a result, you have this impending shortage of care, which has already started. And on page 8, you can see figure 2. This is specific to Texas. The demand for health care significantly outstrips the supply. And this is particularly serious in rural areas of the state. On page 9, you can see this is data from the Texas Health Data website. You can see that we have this heat map of regions throughout the state of Texas in terms of unmet demand for care, where we have computed the percentage of the demand that has been unmet. And this is particularly disturbing in the Panhandle and the Rio Grande Valley, 21 to 37% unmet demand. And you can see other regions of Texas also have a significant amount of unmet demand. So the next page, this is page 10. At the same time, the country has a surplus of talent. The problem is, and Representative Oliverson began to touch on this, there are fewer residency positions than graduates applying. Each year, we have several thousand unmatched graduates without a residency position. The chart in figure 10, which is taken directly from our TPBF paper, depicts this. These are based on calculations done in the Heritage Foundation Center for Data Analysis as well, that by 2022, well, in 2022, I should say, we had over 5,000 unmatched graduates from the main residency match. Now, like I said, without a residency, these medical graduates cannot do anything. And sadly, they are relegated to doing things like selling sunglasses, driving Ubers, or working at Starbucks like Representative Oliverson did. But this is a surplus of talent, and we could use them in the medical profession. So, page 11, you could see, we are faced with a conundrum. We have an existing and impending shortage of doctors and a surplus of talent. So page 12, I should say, what can we do about the situation? Well, we have a number of policy recommendations. Medical graduates have acquired a vast amount of knowledge in their studies. We can tap this surplus of talent to ameliorate the physician shortage. How can we do this? This is page 13. Medical graduates who have graduated from an accredited medical school and have passed the United States medical licensing exams should be eligible for a provisional license to work under the supervision of a collaborating physician. At page 14, this isn't new to this country. This has been done in a number of states. I list a number of states that this has been done in. Missouri, Arkansas, Kansas, Utah, Washington State, and Arizona have pursued forms of this. And this is an opportunity to utilize this surplus of talent here in the state of Texas. So page 15, there's some criticisms, and I'm sure you and your colleagues are going to hear some of these. This could lead, some may say this could lead to an underclass of doctors, and this could jeopardize patient safety. But here's the bottom line. Medical graduates in medical school, they have acquired a vast amount of knowledge, and they're not going to practice independently, and they're not substantially less trained than physician assistants and nurse practitioners who already practice in this type of capacity anyway. And in fact, some of these foreign doctors here, and Representative Oliverson began to touch on this, can be very experienced. They might even have even more experience than the supervising physicians that they're working with. So the next page, page 16,
Kevin, I'm sorry, but
Yeah.
we've got to cut you off. We've
Okay.
got a time
I
limit.
mean, I have one more slide.
Okay, just real quick, I
Yeah.
want to do some housekeeping. I introduced you as Kevin Duranta, Chief Strategist for the Heritage Foundation, but you're testifying on behalf of yourself.
Yeah.
Is that correct?
And I entered that in, Chief Statistician.
Thank you. I just want to make sure we got it for the record correctly.
Okay.
Members, are there any questions for the witness?
Yeah.
Yep. Chair recognizes Chairman Bonin.
Yeah, just real quick, of the several thousand physicians that don't have a position when they apply, are those graduates from U.S. medical schools, or are they predominantly from foreign medical schools? Just
Good question. These are calculated and they're discussed in our paper. These are both American and foreign medical graduates that are either U.S. citizens or green card holders, and therefore they are legally authorized to work in this country.
And that wasn't really the question.
Okay.
I was just trying to get a breakdown. Is this predominantly graduates of U.S. medical schools, or predominantly from, I'm not questioning whether they're here lawfully or whether
Okay.
they're competent or qualified, but rather, do we have enough residency spots for graduates of American medical schools?
There's,
Or,
good question.
Versus we have a lot of foreign-trained physicians who may be perfectly competent, but they're not graduates from U.S. schools. They're wanting very much to come in and get into an American training program.
The system,
To break down
I understand the question.
that
The system is better designed for American medical graduates, but there are still a significant amount of American medical graduates that are unmatched for a variety of different
Yeah,
reasons.
and I think that's a fair point. I just wanted to highlight what my perception is. I haven't studied the data like you
Yeah.
have, that most U.S. medical school graduates actually do match when they want to.
Correct.
So it's not like there's thousands of U.S. medical schools graduates that
There-
can't find any place at all.
It is a non-trivial number of even American medical graduates. Right. Correct.
Members, any other questions? Chair recognizes Representative Morales.
Thank you, Mr. Chair. How is this different from the residency programs that are provided now?
Okay, so the residency programs are formally structured. Like I said, they are accredited by the ACGME, and they are formal training programs meeting a certain syllabus. These would be more, this would be more of the opportunity of giving the license to these unmatched graduates so they could work kind of in the capacity of a PA to work under the supervision of a practicing physician. So there's no formal syllabus per se, like you have in the residency programs. Having said that, I have talked to a number of people about this, and if this becomes mainstream in the United States, then what will happen is the market might respond and create alternative training mechanisms through these licensure schemes.
Will, currently, is the way it is worded, is there a pathway for them to be able to obtain their full residency? No?
I'm sorry, is there a pathway
Well,
from this policy
from this
proposal?
bill, yeah.
No, so the idea is from this bill, they could acquire more experience after medical school and then subsequently apply for a residency afterwards.
Got it.
So it enables them to continue to keep their feet wet and improve their qualifications.
Now, for purposes of, someone like me representing a rural West Texas district, how can we get these, our constituents are basically needing any sort of medical trained physicians that are out there. What can you recommend to us as a body so that we can make sure that some of these folks end up in rural parts of Texas so that they can provide this quality?
Oh, absolutely. So we have talked about this in the paper. So firstly, once the licensure opportunity exists, there will be plenty of people beginning to flock to Texas to pursue these opportunities. Secondly, we have discussed in the past about the availability of these licenses in these underserved areas, and that is also a consideration.
Now, is that currently in the bill?
I do not know, sir.
Okay.
You-
Dr. Oliverson is mentioning nodding yes.
Yes.
And if so, is there, and maybe this is a Dr. Oliverson question, is there a certain number that have to be going to these rural parts or under? No? Okay.
But it's like if there is more of a demand in those areas, then you'll have more
Yeah.
opportunity.
Thank you, Mr. Chairman.
You're welcome. Members, any other questions? No one? Sir, thank you for traveling here and for your testimony. We
Thank you.
appreciate it so much. Quick announcement, there is an overflow room in E2.036 for all those that are standing in the back. If you'd like a seat, we do have an overflow room. This time, the chair calls up Jack Franklin.
Is the goal service?
Good morning, sir. We show you registered as Jack Franklin, representing yourself, and you're for the bill. Is that
Yes, sir.
correct?
My name is Jack Franklin. I am a rural Texas physician in Llano, Texas, about an hour and a half west of us here, and kind of wanted to give you my take on this bill.
Real quick, so we just for clarity, you're representing yourself, though, and you're
Just
for the
myself.
bill.
Yes, sir.
Thank you. You may proceed.
Thank you. Going to keep it under 3 minutes. Rural Texas physicians are a bit of an odd breed. We tend to wear a lot of hats. I'm our Llano Jackets football team's medical professional for our high school. I am the county health authority for Llano County. We addressed COVID crisis and problems that we had with the freezes, as well as several problems with the floods. I've been in Llano County for 25 years. I've worked with the small Llano hospital system when it first existed. I worked with Scott and White later whenever they came in and took over. And in the last 5 years, I've started a direct primary care practice in Llano. So I'm working now as a solo practitioner. So I've seen medical care from multiple different areas. The family medicine doctors in rural areas, we take care of everyone. It's elderly to pediatrics. We do OB. There was one time in my life where I was doing C-sections and doing colonoscopies as a primary care doctor. Through these years and taking care of all those patients, there's always been one common thread, no matter if it was a large hospital system or a small one, we've always needed more doctors in rural Texas. When I started in Llano County, I was the 10th physician in Llano County to be hired. As of last year, I am one of 6 physicians in Llano County. 2 of them are part-time. So it has really gotten to be quite a problem for us. What we in the Hill Country have done is sort of banded together. Llano, Mason, San Saba, Brady, and Junction got together and we worked with the University of Texas, I shouldn't say that, with Texas A&M University, sorry.
Big difference.
That was a bad one. To bring their medical students to the Hill Country to do rural rotations with us for a month. Actually, Mason Dan is sitting in the back. He's a fourth-year medical student at Texas A&M University. He's rotating with me currently. We bring the students there with the idea that they are then going to have a good flavor for rural medicine and eventually go into rural medicine. I think HB 2556 takes that to the next step. Instead of a medical student, we have a medical graduate. Are they going to stay in Llano? Maybe not, but at least they have a flavor for rural medicine and they know what the hat looks like. So that's my testimony, and I hope you'll look forward to this bill.
Thank you. Hang tight. We're going to see if there's any questions for you. Members, are there any questions for the witness? If not, thank you for being here. Safe travels. At this time, the chair calls up Hannah Sani. I hope I pronounced that right. We show you as Hannah Sani
Yes.
testifying on behalf of yourself and for the bill.
Yes.
Thank you. You may proceed.
Thank you, Mr. Chairman. And thank you, members of the committee. My name is Hannah Sani, and I am a medical graduated in 2018 from a British medical school. I am born and raised here in the United States and pursued a global education, hoping to bring back what I learned back to the United States to practice here. Every year, 10,000 medical graduates do not obtain a residency position, the main way to complete your training to become a practicing physician. That is about 3,000 MDs and DOs that have gone to U.S. medical schools, 5,000 U.S. citizen and green card holders that have gone abroad for medical education, such as myself, and about 2,000 visa requiring foreign medical graduates. I am one of those 10,000. Since graduating from medical school, I have applied for residency 5 times, spending almost $50,000 in the process and applying to over 300, sometimes 400 residency programs, all across the nation, and primarily in primary care, which is family medicine, internal medicine, or pediatrics. I have completed all 3 of the required USMLEs, including step 3, which is usually done after intern year of residency. I have research publications in journals, worked for the CDC, as well as volunteered at countless hours across the nation at volunteer clinics. All in the hopes to pad my resume and hopefully become the most qualified I could be as a residency applicant. My passion has always been to practice in primary care, especially in the underserved communities, but due to this residency bottleneck, I am unable to practice in the United States, save a few states that have allowed practice under supervision. My medical degree has literally become useless. For any job, I am either overqualified or severely underqualified because I do not hold a license. Most of the time, I have actually not worked over the past 5 years because I have paid to do rotations, to work at hospitals, to build the networks, and to apply for residency and hope that one day someone will match me. Not to mention, I have over $200,000 in loans that I am unable to pay. I am in a fortunate position that my family has supported me, but I have many colleagues that, as stated before, have worked minimum wage jobs and are hoping that something will happen. The federal government has tried to increase residency spots for the past 10 years through the Resident Physician Shortage Reduction Act, and every time it has failed. Until that passes, we need a solution, and we need it today, just like other states. I had the privilege of going out to Missouri and practice as an assistant physician. I worked in a primary care, and actually I volunteered in a primary care facility, driving 4 hours back and forth from St. Louis to Kansas City to provide care, and then worked shifts, sometimes being the only physician on site, still obviously with a collaborative physician on call at any point, but in urgent care, and all this through the COVID-19 pandemic.
We've got to cut you short there. Well, let's find out if we got questions.
All right.
Thank you. Members, are there any questions for the witness? The chair recognizes Chairman Bonin.
Well, thank you for coming in and sharing your story. It's really helpful to hear what's really happening, to people in the world. And so this legislation, as I kind of think about it, and of course the author can better articulate it, it wouldn't guarantee you a residency spot per se, but it would create an opportunity where you could perhaps practice almost as a physician extender, as a PA or a nurse practitioner under the supervision of another physician. Is that?
Yes. I would actually say you're working more at an intern level or higher. We had somebody that had completed a preliminary year and then joined my urgent care clinic, and he said that we had more responsibility there than most of the PGY1s at his residency. So it's dependent on the person working. There's a designated amount of hours that you're trained with the physician in Missouri. After that, it's up to the discretion of the physician to see if you need more training or can handle a load yourself.
And I wasn't trying to stratify
the
level of responsibility. That wasn't really the point was, as a career path, this would at least allow you to achieve gainful employment.
Yes.
Even if it was more in the role of an extender as opposed to an independent practicing physician, apart from whatever responsibilities you might have in that role. But that would be a happier outcome and more productive for society, in your view. Is that a...
Well, yeah, I mean, I didn't go to medical school to work at Starbucks or do something like that. I've had this dream since I was 10 years old to practice. And someone who's born and raised in California to move to St. Louis, having never set foot in that state to practice, I think that shows my dedication, and I'm not the only one. I found out from others. I have many other colleagues that did the same, coming from all over the country, because that was a state where you were able to do what we have been trained to do.
Thank you.
Chair recognizes Chairman Oliverson.
Henna, thank you, Mr. Chairman. Henna, thank you for being here today, and I'm sorry that you're in the situation that you're in, and I can certainly sympathize. I think part of the issue is, and I think you hit on it, is that we should recognize that there's a monopoly that exists for postgraduate medical training through the ACGME, and if you're not part of their club, then you can't come in. And it doesn't matter how well trained you are or how much experience you have. You're just, you're not a membership card holder. You're not allowed in. And I feel like, based on what you're saying, that's sort of the situation you find yourself in, is as an American citizen who went abroad for medical training, coming back, and then they're basically like, sorry, you're not part of our club. You can't be here. And so this gives you that opportunity to go out. I know my colleague, Representative Morales, is going to ask you this, but based on what you're saying and your experience, I feel like you would be somebody that we could put in a primary care underserved area in rural Texas, and you would function extremely well.
Well, I mean,
in an environment like that, and probably feel somewhat fulfilled from the standpoint of you're actually practicing medicine.
Actually, yeah, that was, to be honest, before I went to Missouri, I felt like a failure. My parents are immigrants pursuing the immigrant dream, and I wanted to be a doctor, and not having any way to support me financially. Like, I worked my butt off to become a doctor. I didn't just come from elitist background where it was, we'll put money wherever. My parents have worked very hard to get me where I am, and to see that all go to waste because of the way the system is set up and not my capabilities. Like, I've had the doctors write stellar LORs, and I just can't get through those filters because of year of graduation, or my score is just not high enough, or I went to a foreign medical school and they don't see me as they don't see me as an American, they see me as a foreigner. And
even though you are an American.
Even though I am an American, and I came back. I went there to come back. That was always my intention. And so those were the difficulties, but until I was able to go to Missouri, I was in a very dark place. And that proved to me in Missouri that this time that I've spent there working proved that it is not me that has failed. It is the system that is failing me and countless others year after year after year.
Well, we need you here, and we want to create opportunity for you to actually get paid a fair wage for the level of training and experience that you have, and really help us with our workforce shortage. So thank you for coming to testify.
Thank you. Appreciate it.
Members, are there any other questions? The chair recognizes Representative Morales.
Is there a community of similarly liked folks like you that interact and either bounce off ideas or opportunities where you may see?
Actually, yes. I founded 3 years ago American Society of Physicians for that very reason. There were 9 of us, 3 of whom have matched into residency. The others, we are either in the process of still applying for residency or have chose alternative career pathways. And it's to provide this kind of support system, because when you go unmatched in residency, you are actually left alone. That is the biggest cohort that is unsupported in medicine right now, and not acknowledged. 3 years ago, when I went public about my experience on social media, people didn't even know unmatched was a thing. And now, every time Match Week comes, I've seen more and more awareness about the issue. And that's our goal with American Society of Physicians. And the thing is, it doesn't just end with not getting to a residency. There are problems downstream as well. But the focus for us is this big issue, is like, how do we get people into the workforce that are qualified?
If you all were provided an opportunity under this bill, how likely is it that you and your colleagues would entertain the possibility of working in rural parts of Texas and in West Texas? I figure that would still be a whole lot better than having to travel to Missouri.
I mean, until this bill is passed, I can't say for sure, but I know that someone like me that grew up in the bubble of the Bay Area, to move to the middle of nowhere in comparison, for me, it's a no-brainer. And I know people that have done similar from New York and Chicago. So it's not a question of if people will go there. It's a question of when will this pass so people can go there, in my opinion.
I envision there's a ton of opportunities in places like my district out in West Texas where people need folks like you that are trained and can provide quality health care in Marfa, Valentine, Presidio, Alpine, those areas. And I'm just wondering, I'm always trying to champion for that sort of profession to end up in rural West Texas just because of the huge need that we have out there. So hopefully, I plan on supporting this with my colleague, Dr. Oliverson here, and I really would like to emphasize the need for rural parts of Texas to have qualified individuals like you.
Thank you, I appreciate it. And I mean, Missouri is underserved communities, that's how they stated it. The Kansas City clinic I was in was rural, which I traveled through from St. Louis, but St. Louis, where I was in the urgent care, that was my primary income, that was my job, whereas the free clinic was in a rural part. So the system, the license, like where you can practice, is similarly structured in that aspect.
Well, if you can just take that message back to your colleagues that are in a similar situated place like you, that would be open in considering rural parts of West Texas. That would be the only thing that I would add to. Thank you.
Yeah, thank you.
Members, are there any other questions? If not, thank you for being here. Good luck to you. We
Thank you, appreciate it.
At this time, the chair calls up David Balot. Thank you for being here, David. We show you as David Balot, Director, Right on Healthcare, Texas Public Policy Foundation, testifying for the bill. Is that correct?
That's correct.
Thank you. You may proceed.
Thank you. Thank you for having me here this morning. To avoid being redundant, we've already had some great testimony. I just want to hit on some points that maybe I would like to highlight again or that haven't been discussed. Again, we have a shortage. I think that's clear. I saw a statistic that was actually staggering to me. Of the 254 counties in Texas, 42 don't have a single primary care physician. Many more are underserved. This bill provides a framework under which graduate physicians can practice care in rural and medically underserved areas under the supervision of a licensed physician. Although unmatched medical graduates are they may currently be able to reapply for residency and subsequent match cycles, their applications are considerably weakened each year. And each year that they're out of medical school and not in the workforce. So graduates are able to gain practice experience, much like Henna explained that she was doing, can maintain or even increase the strength of their application, making it more likely that they obtain residency. We talked about other states that have done this. This isn't theoretical, it's been done. So 6 states have already taken steps in this direction, specifically Arkansas, Arizona, Missouri, Kansas, Utah, and Washington State have all passed legislation allowing unmatched graduates to practice in such capacity. This year, 6 more states are taking this matter up, just like we are, and we are one of those 6. Although there have been no comprehensive studies analyzing the quality of care provided by medical graduates using these licenses, there has been no evidence of quality of care being compromised in these states either. And I'm just going to stop there again to avoid being redundant and not
Thank
making
you
the
for
best
the
use
brevity.
of your time.
Members, are there any questions? If not, thank you for being here. We
Thank you.
appreciate it. At this time, the chair calls up Juliet Madrigal. Is that right? We show you as Juliet Madrigal testifying on behalf of yourself, and you're for the bill. Is that
Yes.
correct?
Yes.
You may proceed.
So I'm Dr. Juliet Madrigal. I work in Marble Falls, Texas in Burnett County. I'm the county health authority. I'm the fire medical director. I wear a lot of hats too. And I can tell you, I love this bill. This would help us so much. Our area is really underserved, and anybody we can get in to help us would be enormously helpful. In my practice, we give discounts to teachers and preachers. We see people with cancer for free. If people can't pay, they don't have to pay. But I can use more help to take care of these people who need me. During COVID, I had to pull my daughter out of college to help me because we were so busy and we had so many sick people. In these rural areas, having these highly trained physicians who don't have a place to go, we will take them in. We will use them, we will teach them, we will make them better, and we will make our community stronger as a result. I really like this, and I really want this to come forward, and it will help so many people in these underserved areas.
Thank you, and thank you for your enthusiastic testimony this morning. Members, are there any questions for the witness? If not, thank you for being here.
Thank you so much for considering this. I think this would be great.
Thank you, ma'am. At this time, the chair calls up Alina Scholar. We show you registered as Alina Scholar on behalf of yourself, and you're for the bill. Is that correct?
On behalf of Texas 400.
Okay, let us change that then.
Yes.
Okay. All right, you may proceed.
Good morning. I support 2556, and I don't know if you guys remember, but back in the interim, I had the honor of testifying about this bill when it's just in its conception. We were just brainstorming on this idea. So now to be here again, it's really exciting to come to this point and think that we could do something so simple to help so many. And it really comes down to that. It is pretty simple, so that we could bring physicians directly into rural and underserved areas in a rather quick fashion. There's not a lot of rollout to go with this. So today, addressing this critical issue, I want to make one more point of reminder in terms of the rural physician and underserved physician shortage. Texas ranks 47th in terms of primary care physicians. That's terrible. Now, us Texans don't like to be at the bottom of the heap, so we need to do something about this rather quick. So, as you've heard, despite adding more medical schools in Texas, more graduate medical education programs, we still, according to May 22's DSH's report, we're still going to be short on physicians. We're going to be about 10,000 short by 2032. So we've got to ramp up this rather quickly. Just in primary care physicians alone, we'll be 6,000 short by 2032. So today, almost 38% of residents in RGV don't have access. 27% in East Texas, 22% in the Panhandle. So this is an all-hands-on-deck situation, and these folks are ready to go. As you heard, they're very excited about us potentially having this bill. They want to move to Texas. They know Texas is a great state, and they're ready to come here. The other thing I wanted to mention, because the question always arises, and I kind of hate to say this, but everybody asks, well, why didn't they match? What's wrong with them? And the answer is nothing. Nothing is wrong with them. This is a statistical issue. So there's 0.8 positions in residency for every one graduating physician. Then on top of that, you add an algorithmic process of the match that's going to leave people on the sidelines. It's the way it works is mathematically odd, and you're going to have people left out. There are 8% of United States DO graduates and 6% of U.S. MD graduates and about 40% of international graduates that are not going to match. What an untapped idle workforce that we could tap into rather quickly. The other point I wanted to make is these graduates are only 1 year away from practicing. So if they practiced in a residency in Texas for 1 year, they could actually leave residency and go practice. So that 1 year gap is what we're missing. So let's get these folks into our workforce. Let's strengthen their GME applications. And as we in Texas ramp up our self-funded GME, then we're going to have spots for them to match into. Finally, I myself, I'm a plastic surgeon, but I have 2 primary care practices here in Austin and in San Antonio. My San Antonio practice is in an underserved area. I myself would vow to you that I would bring a physician graduate into my program. I would be happy to do so and really honored to be able to mentor that next generation of Texas physicians. We bring them here, we keep them here, we take care of our folks.
All right, let's see if there's any questions. Thank you for your testimony. Members, are there any questions for the witness? If not, thank you so much for being here.
Thank you.
At this time, the chair calls up Patricia Arona. All right. We show you registered as Patricia Arona, Texas 400, and Texas Physicians for Patients PAC, and yourself. Is that correct?
Yes, sir.
And you're for the bill?
Yes, sir.
Thank you. You may proceed.
Yes. Thank you, committee members, for letting me testify today. As the others have said, I'm definitely for this bill. I think it's a great opportunity to help meet the needs we have for more physicians, especially in primary care in Texas. As a senior citizen, I've really witnessed an awful transformation of the practice of medicine in my lifetime, from a time when your primary care doctor took care of you from cradle to grave, to now having a system where a common refrain is, I can't get in to see my doctor. And people are just not able to see a doctor because we don't have enough of them. When I was in med school 50 years ago, there was a buyer's market. There were more residencies than there were people to fill them. But then the match came along and totally turned things upside down. And we now have this horrible system that is turning away good people like Henna, not giving her an opportunity to be able to practice medicine. And it's tragic to see what's happening. So we have people who, as Alina said, are good, qualified people. It's not an easy thing to get into med school in the first place. And then to pass the licensing, the first two parts of the licensing exam is not a walk in the park. So they're not stupid people. And it's the system that's keeping them from practicing medicine. They're coming into a system, if this bill passes, with way more training than the NPs and PAs that we have out trying to help fill the need. So instead of substituting non-physicians, we need to use these people who have all this training. And I want to add, people have talked about the unmatched getting jobs as Starbucks baristas and Uber drivers. There's also the tragic fact that every year somebody commits suicide. That this is a horrible thing. They come out of medical school with upwards of $250,000 of debt and no job and no way to work. And that's a tragedy that we should not be contributing to. So this is a way, this bill would let these people actually work for what they've spent their whole lives training to do. They want to practice medicine. I mean, if there's one thing about them you can be sure is not only do they have 2 full years of supervised hands-on clinical training, but they're coming out ready to work, knowing what they don't know, and eager to learn more and eager to be able to fill a need. And so I think it would be a wonderful thing if this state passes this bill. And I would just add to the list that David gave you of the states that have passed it. In the last 2 weeks, Louisiana has passed a similar bill that will allow the unmatched residents to work in Louisiana. So we should not delay in passing this bill.
Thank you so much. Members, are there any questions for the witness? If not, thank you for being here, ma'am. At this time, the chair calls up Tiffany Ostovar Kermani. I hope I got that correct. All right, will you do us a favor and just
Yes.
state your name?
Yes. Good morning, everyone. Thank you for this unique opportunity. My name is Tiffany Graham Ostovar Kermani. I'm a graduate and physician and surgeon of the United States, or the U.S. UAG, which is Universidad Autónoma de Guadalajara School of Medicine. It is one of the best schools in Mexico. I selected to go there.
Hang tight. You're
Yes.
testifying on behalf of yourself
Yes, I am.
and for the bill.
Yes.
Now you may proceed.
My apologies. I graduated in 2010, and since then have been highly involved in medically underserved areas of Houston and the Metroplex area. Since graduating, I have worked in the Texas Medical Center at 2 reputable academic institutions as a clinical researcher with direct patient care. And I also am currently a postdoctoral fellow at the Ruth R. Krichtenstein Primary Care Research. My goal, in addition to serving my community, is to volunteer currently as a medical assistant, which I did seek that certification so that I could have direct access to patients. So in my role as a medical assistant, even though I am a physician and surgeon, I have seen people from Afghanistan, Cuba, Haiti, the Republic of Congo, and many other countries, including Pakistan and India. My goal is to provide care, bilingual care, to the community. Excuse me, I'm very nervous. This is my first time. So I co-manage also a campaign to provide vaccines to people who are interested in receiving vaccines for care. So I believe that HB 2556 will certainly help me as a physician, but from a patient perspective, which we are all someone's patients, would certainly provide care, primary care specifically. So as you all know, without repeating, Match Week recently occurred. I did not apply because I could not afford to. Along with my colleagues here, there's certainly a need for us. We understand that there's some trepidation, some concerns regarding the bill. However, we are certainly in need of people like me who can provide bilingual care to physicians as well as non-physicians. And so I want to make sure that you understand that I have been a qualified physician for many years. One of the rejection letters that I received was, please know it's not a reflection of your capacity or your abilities as a surgeon and physician. We just don't have enough spots to train all of you. So please consider this HB 2556 as to provide us with the rural and urban care that we can give. I personally am interested in rural care. I am committed to health disparities, reducing those health disparities for people who can speak Spanish and English, and that is across the diaspora around the world. So my skills are certainly needed, and I appreciate your time today.
Thank you. You did a great job, even being nervous. Members, are there any questions for the witness? The chair recognizes Representative Morales.
I just want to again emphasize thank you for your testimony today. And I'm familiar with Universidad Autónoma de Guadalajara. I know that a number of my friends and constituents in Eagle Pass and Del Rio have participated through that program. And so do you have any data that would show how many of those folks that actually attend the Universidad Autónoma de Guadalajara end up not getting residency?
I do not.
Okay. And do you know, though, just generally if it's enough of an issue where they don't get it just because they go out of the country to get their medical training?
Yes, absolutely. In fact, I've reached out to my school and presented them with the circumstance that I'm in, and they are currently working on a way to provide us sort of a bridge to improve and enhance our applications for residency. I personally, from this program, have 5 years of clinical experience in both rural and urban areas of Mexico. That's all of Mexico, which is where we're sent to practice in that country. However, I don't have specifics on how many do not match, but I am very aware that most of us are either working in clinical research, basic research. Even one of our partners became an attorney, but this is certainly an untapped resource.
There's a lot of that.
Yes.
My experience with that school shows that many of the residents that end up going through it are bilingual in nature. Has that been your experience as well?
Yes.
And do you understand that would be extremely beneficial for parts of West Texas and South Central Texas that are rural in nature, where you need, because of the constituency that is there, most of them either are Spanish speakers or primarily speak Spanish, and how somebody like you and other colleagues like yourself would be crucial in representing areas like that?
Yes.
And would you be open to representing areas in rural Texas?
Without hesitation.
Thank you, Miss. Appreciate you.
Thank you. Members, are there any other questions? If not, you did a great job. Thank you for being here. This time, the chair calls up Stephen Carlton, Executive Director, Texas Medical Board, testifying neutral. Good morning.
Hi, good morning.
You may proceed.
Thank you. I'm Stephen Carlton, Executive Director of the Texas Medical Board. I'm neutral and here as a resource witness, and just happy to answer any questions you guys may have.
Thank you. Members, are there any questions for the resource witness?
I'd like to ask.
Absolutely. The chair recognizes Vice Chair Howard.
Thank you, Mr. Chairman. Just to help me understand better what the situation is here, I know that in terms of appropriations anyway, for quite a few years now, we continue to address the GME slots and try to get more and more funding for those. From your vantage point, what is the issue here in terms of having sufficient slots in the first place to address the need that we're hearing about?
As has been testified to earlier, I mean, it does appear that there are just a lacking number of spots in residencies for the number of people that are graduating from medical school each year. And so with that does create a barrier. As you heard testified to earlier, an individual has to have at least 1 year of this postgraduate training to get a full license in Texas. And so without that, that does leave that gap that they'd have to just keep applying over and over again.
So I know we've been trying to achieve a one-to-one match. The appropriations chair, I'm sure, can address this and will. But I know we've been increasing funding trying to meet that need. There's still a gap, though, you're saying. We're not getting where we need to be in terms of having sufficient slots.
That's our understanding from the medical board's perspective, yes.
Okay, thank you.
The chair recognizes Chairman Bonin.
Yeah, thank you. And as a disclaimer, I used this once last session. I reserve the right to be wrong about my comments, but I think our goal was to say that as we create more medical schools, more medical student positions in the state, we want to make sure that we have enough residency spots. However, that would be for the graduates that we're producing. It would not include graduates from all around the country, much less all around the entire world. And so you'll never reach the end, unfortunately. And we do continue to have new medical schools and new Texas graduates. But we want to at least have positions for the students who graduate from a Texas school. But a separate question, just to make sure we're clear. So would you have licensing authority over this population under this statutory provision, should it pass?
Yes, because they would be physicians. It would be a limited physician license, but with our regulatory authority over physicians, this would put them under our purview.
So this would create a different lane, if you will, under which they would operate, because they haven't completed an internship or a residency, but yet they can practice with the appropriate safeguards and under the supervisory construct described in the bill. Is that fair representation?
Yes, as the bill is currently written, they would have to be supervised by a sponsoring physician. They would have to have delegation. So as also you've heard earlier, they would operate similar to a physician assistant or a nurse practitioner.
And without this bill, they can't do that?
They would not be able to operate under that scope. A physician can use people kind of and delegate and supervise certain things to them, but as you heard, they're kind of surgical assistants or some sort of a medical assistant. It would not, correct, it would not be to the level of this kind of a limited physician.
Okay, thank you.
You bet. Members, are there any other questions? If not, thank you for being here. Is there anyone else wishing to testify on, for, or against House Bill 2556? If not, the chair recognizes Chairman Oliverson to close on the bill.
Thank you, Mr. Chairman and committee members. I think hopefully you got a sense of the enthusiasm for these folks and their willingness to come. And I think really the only barrier right now is just we have to pass this bill and create this pathway for them. And if the pathway is open, they will come, and they will be a tremendous asset to fill gaps in our healthcare workforce. So one thing I didn't mention earlier, but as the medical board director was up here, the other thing is that as part of this licensure, we would want them to also meet some of the requirements for licensure maintenance in terms of we've talked about wanting them to do some continuing medical education as well, so that they're sort of in the same boat as physicians. Obviously, there's not a board certification to worry about or deal with, but we want them to be treated like physicians and feel like physicians from the standpoint of the licensing body and having some of those continuing education requirements. So I think that's just one more positive that I forgot to mention as far as helping them to grow intellectually in terms of honing their skills. So with that, I'd ask for your favorable consideration, and I close.
All right. If there are no objections, House Bill 2556 will be left pending. Is there objections? The chair hears none. House Bill 2556 is left pending. The chair lays out House Bill 999 and recognizes Representative Price to explain his bill.
Mr. Chairman, thank you for allowing me the opportunity to lay out House Bill 999. I appreciate that, Vice Chair Howard and members. If passed, House Bill 999 has the potential to improve the cost of medication for specific populations who depend on them. This House bill is driven by health plan enrollees, including persons with varied diseases and disabilities who rely on their medication to function. Insurance plans, as you know, are selected by enrollees for varied reasons and based on personal needs. For many, including those with chronic pain, bleeding disorders, immune deficiency, cystic fibrosis, and other conditions, The selection of insurance involves choosing a plan based on whether their medication is covered and if they can afford the premium. In the commercial health insurance market, patient deductibles and copays continue to increase. As patients face more out-of-pocket costs to access their covered medications, many have become increasingly reliant on third-party assistance to afford their needed treatments. Many third-party entities, including pharmaceutical manufacturers, patient assistance programs, nonprofit foundations, et cetera, they offer cost-sharing assistance and/or copay vouchers or coupons to help patients better afford their out-of-pocket costs. These assistance payments are what are being blocked from counting towards a patient's out-of-pocket cost-sharing requirement. In other words, the amounts not paid directly by the enrollee, but made on their behalf are being prevented from applying toward the enrollee's deductible or out-of-pocket maximums. Often, patients are unaware that their health plan includes a copay accumulator program that is what it's referred to in their plans, and are surprised at the pharmacy counter when they learn that the copay assistance funds were not applied to their deductible or their copay, and then they continue on their prescribed and covered medication, and then the patient has to pay the full cost of their medicine until they again reach their deductible. So what this bill is intended to do, if passed, it'll require insurers to include any third-party payment made by an enrollee or made on their behalf, including financial assistance, discounts, product vouchers, or other reduction in out-of-pocket expenses that they would count towards the payment of the enrollee's deductible, co-payment, cost-sharing responsibility, or out-of-pocket maximum. It protects patients from policies that make it more difficult to afford their medication. Be happy to answer any questions from the members, Mr. Chairman. With that, I'd like the opportunity to close.
Members, are there any questions? Chair recognizes Chairman Oliverson.
Thank you, Mr. Chairman. And Representative Price, I appreciate you bringing this bill again. I know we worked very hard on this all session long in the Insurance Committee last session, and I want to commend you for filing the bill as it left our committee last session, which I felt was a very good compromise. It's really important in a situation where there are no alternative medications, there is no generic, so there's nothing to drive the price down. And then the patients are sort of caught in this lurch of where they have this massive cost sharing for the only drug in its class, and there's really nothing they can do about it. And so I feel like that's an appropriate use for these cards. I do have concerns, and you and I have talked about this extensively, but when there are therapeutic alternatives, and by that I mean generics or competing drugs in the class, I feel like allowing these cards or mandating that these cards be counted essentially destroys completely the ability of a insurance company to be able to enter into good faith negotiations with a manufacturer for an appropriate price discount through the plan, because essentially there's no incentive, right? If patients are angry, I just slide them the card under the table and then their cost sharing is the same and it's the employer that gets gouged. So I feel like that's an important dichotomy, and I hope as this product moves forward that we continue to respect that we want to protect those who are truly without other options. And at the same time, we're not trying to incentivize a failure to negotiate on behalf of big pharmaceutical companies and insurance companies, because I feel like they need to have that conversation. They need to aggressively negotiate with one another for the benefit of employers and patients.
Well, thank you for your, Mr. Chairman, ma'am.
Please proceed.
Yeah, thank you. Thank you, Dr. Oliverson, Chairman Oliverson, for that feedback, and thank you for working on the bill. As you remember from last session, passed out of your committee in the form that we're presenting it in today, with language included that really carves out generics and biological products that are available, so that if a specific population really is relying on a drug that has no therapeutic equivalent or alternative, then this would apply. But otherwise, it would not. And it's important to remember all the drugs that we're talking about are on the plan's formulary, so they're already covered. So if the bill were to apply and copay assistance or any assistance, third-party financial assistance, patient assistance programs from a manufacturer, so to speak, applied, that rebate back or that assistance is being made to a drug that is already approved by the plan already. And in 16 other states where similar laws have passed, we have seen good data about where the effect is on plans and the premiums paid. And I am confident that if we pass this bill, we'll also see that exact same thing happen right here. And it really does impact and benefit the very specific populations that rely on what sometimes is referred to as orphan drugs. And so thank you for your work on the bill, and thank you for your feedback, and I appreciate again this committee's opportunity to consider it.
And I'm grateful to you, and I know you're also getting, suggested language and pressure about, I think the term is therapeutic alternative, and I think we have to be also mindful that the language is critically important here. In the case of someone who's suffering from hemophilia, a therapeutic alternative to a biologic medication may be blood transfusion. But I doubt that any patient struggling with hemophilia would feel like that was a fair alternative.
I can assure you they don't.
And the risks are clearly not the same. So language is important, and I look forward to continuing to work with you on this, and I'm really glad that you brought this bill back. Thank you.
Thank you, Mr.
Yeah, and I want to compliment both of y'all, Chairman Oliverson and Representative Price, for working so diligently on this. I know there's been a lot of back and forth on it, and we appreciate y'all working together. Members, are there any other questions? If not, we're going to proceed to testimony. At this time, the chair calls up Kendall Boyer. Kendall, I'm sorry. At this time, the chair calls up Kendall Boyer, Director of Advocacy, Infusion Access Foundation, and self. You're testifying for the bill, is that correct?
Yes, that's correct.
Thank you. You may proceed.
Yes, hi. My name is Kendall Boyer. I'm the Director of Advocacy of the Infusion Access Foundation. So before arriving today, I spoke with a patient, Megan Ryan, who receives infusions every week. With these infusions, Megan has successfully managed her diagnosis of common variable immune deficiency and has lived a very full life here in Texas. Megan has been stable and able to receive her infusions without issues until just last month. Megan uses copay assistance to cover the cost of her medication. However, Megan recently learned that her insurance has instituted a specialty copay offset benefit. This benefit ensures that Megan's copay assistance will not be counted as legitimate payment. Her insurance company will now pocket any funds from Megan's copay card while also charging Megan. Given that Megan received her infusions like normal at the beginning of the year, Megan was hit with a surprise bill from her insurance company just last month. The bill indicated that none of the funds from her copay assistance counted toward her deductible or out-of-pocket requirements. Her insurance company was paid real money, but now Megan is on the hook for the amount already paid. All of the patients I encounter through my work have overcome incredible hurdles before obtaining clinical stability with an infusion or injectable product. Naturally, these complex drugs can be extremely expensive. Patients know this, their doctors know this. That's why most, if not all, patients I interact with arrive at a treatment plan that is not only medically appropriate, but also covered by their insurance. If a treatment is not covered by their insurance, the enrollee will have to receive prior authorization or have to go through a step therapy protocol to receive coverage. Only then, and after they have received insurance approval for coverage, do patients seek third-party copay assistance to help cover the cost of these drugs. Megan has said herself that without weekly infusion treatment, she would face persistent and potentially fatal infections. Please do not leave it up to patients to choose whether they must forego their covered treatment or be devastated financially. Please vote in favor of HB 999 to make sure that copays count towards their health plan's deductible or out-of-pocket maximum. Thank you.
Thank you. Members, are there any questions for the witness? Seeing none, thank you for being here.
Thank you so much.
At this time, the chair calls up Ryan Crow, Texas Bleeding Disorders Coalition, and self testifying for the bill. Is that correct?
Yes, sir.
You may proceed.
Distinguished members of the House Select Committee on Healthcare Reform. My name is Ryan Crow. I'm a 44-year-old living with Factor IX deficiency, more commonly known as hemophilia B. I run the Economic Development Corporation for the Pumpkin Capital of Texas, better known as the City of Floydada, north of Lubbock. I also serve as board president for the nonprofit Texas Central Bleeding Disorders, representing people with hemophilia and other bleeding disorders across the northern part of the state. Through that role, I am also an advocate for the Texas Bleeding Disorders Coalition. I'm here today to tell you about my experiences with living with hemophilia and about why we as a coalition feel as strongly as we do about the need to stop copay accumulators. A brief rundown. I was born in Dallas in 1979 under the watchful eye of the Hemophilia Treatment Center at the hospital now known as UT Southwestern. When I was 4, I fell backward onto a concrete floor and caused a subdural hematoma, or bleeding between the brain and the skull, requiring a craniotomy that's left me with a 6-inch scar along my occipital nerve, which causes me pain to this day. I have joints of a much older man, and despite being built like a linebacker, I never got to take the field for the Fightin' Rains Wildcats of Emory, ending my sports career at junior high basketball after too many bleeds into my right ankle, again resulting in pain I live with to this day. I endured years of quarterly HIV tests, losing friends and family to a curse that I somehow avoided. I live with survivor's guilt to this day. In 1995, I was diagnosed with hepatitis C, a virus that claimed the life of my mother in 2004. Thankfully, following a year-long treatment not dissimilar to chemotherapy, I cleared the virus in 2007. Today's treatment is much easier and much more effective. All that brings me to my need to advocate. My wife is a college professor. I have an excellent job in economic development following more than 20 years in broadcast journalism. We live a comfortable, sensible, middle-class life with our 12-year-old son. But we are not immune from financial troubles, having to declare bankruptcy in July of 2020 due to my medical bills following hospitalizations and medication costs. Currently, the insurance I am on through my wife's university does not have a copay accumulator. So thankfully, I'm able to receive assistance from the company that produces clotting factor that I have been on since 2015. I cannot say the same for my blood brothers and sisters who receive similar assistance for their life-saving medication, only for their insurance companies to pocket the money as a, quote, cost-saving measure on their part. The reasons given for this action is to make sure patients have either skin in the game or to force doctors to prescribe a cheaper alternative. For us, a cheaper alternative does not exist. There is no generic factor I'm able to take. Of the handful of products currently on the market for hemophilia B, my doctor and I came to the decision my current product was best for me after attempting other treatments. Forcing patients like myself into paying full yearly deductibles before accessing factor can and has led to rationing of medication, which can and has led to much greater issues like further joint damage and costly hospitalizations. As stated previously, I have already borne the burden of bankruptcy, and even after that, still pay roughly half my amount of my mortgage each month in medical bills. I do not wish to continue with the threat of financial ruin hovering over us as we prepare for our and our son's future. I thank you for considering halting copay accumulators in Texas and taking the bipartisan approach to enact legislation that has proven workable in multiple other states for the benefit of patients like myself. Thank you.
Thank you for your testimony, members. Are there any questions for the witness? If not, thank you. This time, the chair calls up Melissa Compton, Texas Bleeding Disorders Coalition, and herself testifying for the bill. Is that correct? Yes. Thank you. You may proceed.
Thank you, Chairman Harless, and the committee for hearing our testimony, and thank you to Representative Price for his work on this bill, again, to protect Texas patients' access to life-saving drugs with HB 999. Like I mentioned, I'm speaking professionally as my role mentioned, but also personally on behalf of my 20-year-old son who has severe hemophilia A. I'm also speaking to you because I know Texas can do better. Many patients rely on the patient assistance programs offered by pharmaceutical companies and nonprofits like the PAN Foundation to meet their copay requirements. These payments are given directly to the insurance, not the patient. They are different than the coupons you might use at a local pharmacy. They provide assistance to patients who have extremely high out-of-pocket costs, often in the first month or two of the year. Insurance companies have implemented copay accumulators on many Texas health plans and are not accepting the patient assistance to count toward the patient's copays. Think of it this way. You're a college student with a $10,000 tuition bill and you've earned a $5,000 scholarship. You go to pay your $10,000 tuition bill thinking you're going to pay $5,000. The university has pocketed that $5,000 scholarship, but asks you to pay the full $10,000, ultimately getting $15,000 for your original $10,000 bill. Is this fair? This is happening to patients all over Texas, and it needs to stop. These programs have hurt our community and threatened to take us back to a time when treatment was not even an option. Hardworking families are unable to access their medication and have to take out loans, not pay their mortgage, or just not take the medication. My husband and I have kept our son Kyle compliant, infusing him 3 times a week for 20 years. He has had 1 bleed in his entire life. Today, he's a healthy junior at Texas A&M. And this year, with a copay accumulator adjuster on our policy, any assistance we have received this year has been accepted by the insurance company but not applied to our copay. We are now making the decisions I mentioned earlier. Do we pay for his medication and not for his tuition? According to a study by the AIDS Institute in February, where Texas received a D grade, 11 of 15 plans in Texas have a copay accumulator program in place. We can join the 16 states plus Puerto Rico who have passed legislation to ensure patients can utilize these programs as they were intended. A study done by the Global Healthy Living Foundation last November shows that allowing copay assistance to count toward a patient's deductible does not increase premiums. It actually lowers costs. It allows patients to remain compliant, out of the ER, prevent disease progression. It allows kids like my son to continue pursuing their dreams of being a contributing member of society, raising a family, and holding a job. The treatments are available. Yes, they cost a lot, but these patients are worth the cost. The system is broken. High drug costs and various other practices make it difficult for patients to navigate their health care, but this is making it even harder. Health plans will tell you patients are driven to high-cost name-brand drugs. Like mentioned before, patients with bleeding disorders do not have a generic option. They'll tell you we have no skin in the game, no personal cost. We still pay our premiums, multiple doctor visits, lab work, and ancillary supply costs. Health plans still determine their formulary, and patients must still go through the utilization processes that they've put in place. I know Texas takes pride in being a very business-friendly state and are concerned about cost to employers, but employers will lose employees if they cannot stay healthy.
Thank you, Ms. Compton. Let's see if there's any questions for you. Members, are there any questions? If not, thank you for being here. Thank you for your testimony. At this time, the chair calls up Julie Frederickson Jones on behalf testifying for the Texas Bleeding Disorders Coalition and self for the bill. Is that correct?
Yes.
You may proceed, please.
I am a lifelong Texan living in Capel with my husband and 3 children. I want to thank the committee, Chairman Harless, and Representative Price for filing HB 999 to make all copays count. I am the executive director of Texas Central Bleeding Disorders, a nonprofit that serves Texans living with bleeding disorders and their families. I am also the co-coordinator of Texas Bleeding Disorders Coalition, an advocacy organization that works to protect our community's access to care. I am here today asking you to carefully consider supporting House Bill 999 that would eliminate copay accumulator programs from health plans. The implementation of these programs on health plans of patients in Texas is detrimental to the treatment of their chronic conditions, as well as their overall physical and mental health. While advocating for the bleeding disorders community is in my job description, I also have a very personal connection to this community, which serves as the fire in my soul to always stand up for what is in the best interest of those living with bleeding disorders. My late husband, Chad, had severe hemophilia A, and my daughter is a carrier and has mild hemophilia. When my husband was born in 1966, treatment looked much different than it does now, and his parents were given a very grim prediction of what his life would look like if he lived. Fortunately, he was tough as nails and incredibly ambitious and managed to live into adulthood, but not without hemophilia and the absence of treatment taking its toll on his body. By the age of 42, he had endured hip, double knee, and shoulder replacement surgeries. The joints in his ankles, wrists, and elbows were all fused from the damage of years of bleeding into his joints. He spent every day in a kind of pain that most of us cannot even imagine. He spent countless days in bed, unable to walk due to massive swelling and intense pain. He could not throw the ball with our son. He could not carry our daughter. In 2018, Chad died from complications of HIV and hepatitis C, which he acquired from tainted blood catastrophe in the late 1980s. I do not share my story for sympathy for me or our children. I share his story to show how far we have come in treatment. I'm going to stop right here and add, Representative Oliverson mentioned blood transfusions. Those were the type of treatments they attempted on Chad when he was a child in the hospital. And while it did slow down a bleed, it is not as effective as the medication that is available today. Advocates in our community have a long and determined history of fighting for what is right and fair. We have safe blood products because of that history. But now access to these amazing treatments are in jeopardy for so many because of the financial hardships caused by copay accumulator programs. It is shameful that in 2023, patients and their families are choosing between paying their mortgage or getting medication, choosing between a vehicle to drive to work and school or getting their medication, choosing between returning to their next semester of college or getting their medication, and so many more hard decisions no one should make. With medication to treat bleeding disorders, there is no grim prediction of what life will look like. So I am here today because it is in my job description. But more importantly, I am here today to protect the patients who deserve better than Chad.
Thank you for your testimony. We're sorry what you and your family had to go through. Members, are there any questions for the witness? If not, thank you for being here today. At this time, the chair calls up Ezekiel Silva. I hope I pronounced that right. We show you registered as Texas Medical Association and Texas Radiological Association, and yourself testifying for the bill. Is that correct?
That's correct, Mr. Chairman.
You may proceed.
I'll keep it more simple. I go by Zeke. My name is Zeke Silva. I'm a physician. I practice diagnostic and interventional radiology in San Antonio, Texas, and I'm speaking on behalf of the Texas Medical Association and our more than 57,000 members. I'm also testifying on behalf of the Texas Radiological Society and our 2,900 members. I'm testifying for House Bill 999. I base that on the fact that these copay accumulator programs, as Representative Price nicely laid out, are detrimental to patient care. I mean, as a physician, I agree with every story that's been told this morning by those that testified bravely before me. That's what we see in our practices. That's what our members see. It's not just chronic illness, however. It's often a more acute condition. It's often a condition where there's limited treatment options. These programs, these manufacturers' coupons enable these patients to literally receive life-saving treatments. I won't repeat the patient stories that we see, but I would like to comment on what this means for the other stakeholders involved, specifically physicians and the health plans. Think about the benefit that the health plans have and why they've implemented these programs. They essentially get paid twice. They essentially get paid when that manufacturer's coupon is used by that patient, because they're not responsible for that financial outlay under this program, but also as patients approach their out-of-pocket maximums, their deductibles. These plans no longer have a responsibility for those costs as well, because these costs simply do not go towards those important calculations. But I think most importantly, it's for we as physicians, is we see these patients, we see their need, we see an option to provide these treatments, and we hear the frustrations that these patients express back to us regarding their inability to do so, to achieve the wellness that they deserve. There was a comment raised regarding the possibility of this increasing prices. I think the language in the bill regarding generic drugs and also biological equivalents, I think addresses that question. We do support that language, including the mention about prior authorization and other means to achieve those, or at least the initial screen that those went through. But I do want to make the point about physicians and how we think about these patients is we don't base our decision-making on whether a drug is expensive or inexpensive. We base our decision-making on what is best for that patient, how that patient can achieve the best outcome, and we expect programs like this to not step in the way of that ability. Mr. Chairman, thank you.
Thank you. Thank you for your testimony. Members, the chair recognizes Chairman Frank.
Thank you, and I totally agree with you that much of the system is broken, lacks competition, transparency, all that good stuff, but I'm trying to understand the actual transactions, because obviously we need to do better by the patients. I'm not arguing that. I just want to understand the transactions of who's paying what to whom. So give a coupon. Can you walk me through what actually happens? And you may not be the right person to ask, but I want to.
I'm not sure I'm the perfect person to ask, but I'll make an attempt, and I think that could prompt some discussion. Yep. So imagine a patient has a condition and they have a manufacturer's coupon.
And let's use a $5,000 deductible, right? High deductible plan.
High deductible.
It's the only service you're going to get this year is.
Right. They haven't reached the deductible. Let's say the medication costs $1,300, just for example. The coupon allows that patient to go to the pharmacy, receive that medication for a lesser amount. Let's say it's $1,000 less at $300.
Okay.
For our patients, even though $300 is less than $1,300, it's still real dollars and cents for them. So that patient would expect that that would count towards their copay or at least their deductible calculation. So they're sort of in this double jeopardy position where they're paying for the amount that the coupon allows to receive the medication, but yet they're still paying premiums to a health plan, and the payment that they just made is not counting towards the deductible that, given their condition, they're very likely to reach during that period.
Okay, so what does the pharmaceutical company get? Trying to figure how much money in that example, right? Cash goes in 300, and maybe I'll need to do this offline, but so the pharmaceutical company gets $300. Okay, and I guess
I'm not the right one.
Well, then I may do it offline because we've got to find a better way. But the challenge is also sometimes we protect the front end so much there's absolutely no control on how much the pharmaceutical company now charges the insurance company, which absolutely gets passed on to premiums and absolutely causes people to be uninsured because the premiums cost 2 or 3 times more. So we need to fix the problem in the short term, but not make it worse in the long term. And so,
thank you.
Maybe there's somebody else.
No, and I agree, Chairman Frank. The point I made about we as physicians, we're aware of those dynamics, but really our decision making is in the best interest of the patient. And if that's a way for our patients to receive the treatments they need and require and deserve, it's a means for us to attain.
Somewhere, I think, in our system that is literally twice as expensive as the rest of the first world, we have. At some point, there has to be some discussion of how much stuff costs because we're literally pricing people out of the ability to get health care with the decisions that and I'm not talking just you, because it's honestly most of the problem is with politicians or started with politicians. So thank you.
Thank you. Members, are there any other questions for Dr. Silva? If not, thank you for your testimony.
Thank you. Thank you.
At this time, the chair calls up Rachel Neeland, Bleeding Disorders Coalition, testifying on behalf of the Bleeding Disorders Coalition and herself, and you're for the bill. Is that correct?
Correct.
You may proceed.
Good morning. Thank you, Chairman Harless and members of the Healthcare Reform Select Committee for listening today. I'd like to thank Representative Price for once again supporting Texas patients introducing House Bill 999 this session. My name is Rachel Neeland, and I live in Dripping Springs with my husband and 3 kids. My 2 boys have severe hemophilia, and after they were diagnosed, I myself, after a lifetime of bleeding issues that went untreated, was diagnosed with mild hemophilia, a genetic bleeding disorder that prevents the blood from clotting properly. It can be dangerous and even life-threatening when a patient experiences a severe internal bleed into joints, muscles, or organs like the brain. Hemophilia is complicated and expensive disease to manage. Just 40 years ago, the life expectancy of someone with hemophilia was 12 years old. If they lived past that, they would most likely not be able to walk. But thanks to research, innovative therapies have been developed that allow hemophilia patients today to live almost completely normal lives with a full life expectancy. These therapies, however, are very expensive. There are no generic options for us. Treatment is very individual, and as cost of health care rise, the out-of-pocket costs from patients rise. My family is very thankful to have the copay assistance programs. All of the pharmaceutical companies that manufacture hemophilia drugs provide to their patients these programs, help us have access to medications that we would otherwise be unable to afford because our drugs are so expensive. My sons and I meet our out-of-pocket maximums the first month or 2 of the year, unlike most people who spread this out $100 here or $100 there through doctor visits or regular prescriptions. 5 years ago, my family was unaware our health plan had placed a copay accumulator program on our insurance policy. It's not very clear in the policy what a copay accumulator really means, but at that time, I tried to refill my prescription for my clotting factor. We had relied on the copay assistance the past 2 months, and I thought had met our out-of-pocket max. However, before I could receive that next shipment of medication, our insurance company was demanding we pay $10,000. $10,000. They had accepted the assistance money, but did not apply it to our deductible and was requiring us to pay the entire amount of out-of-pocket as well. I call this double dipping. How was my family supposed to come up with that kind of money? My son has now endured 5 knee surgeries, missed more school than I care to count, and suffered mental health issues because of his struggles. Since then, I've had to have surgery related to hemophilia and also not allowed to use the copay assistance program. My family has been making monthly payments since 2018 to try and pay these bills. While the insurance company has already collected the original out-of-pocket from the copay assistance program. While our medication is expensive, we don't have access to the medication. It is even more expensive. Trips to the emergency room can be up to 10 times more expensive. Disease progression and complications, unnecessary surgeries, missed school and work, and a strain on our mental health, all things my family has experienced because of the copay accumulator on our insurance policy.
Rachel, let's stop you right there and see if there's any questions from the members. If not, we've got to stop you there, and thank you for your testimony. Good luck to you and your family.
Thank you. I left a photo book so y'all
I got it. It's awesome. Thank you. At this time, the chair calls up J.P. Summers. JP, we show you registered for Global Healthy Living Foundation and yourself.
Yes.
For the bill. Is that correct?
Yes.
You may proceed.
My name is JP Summers. I grew up in Abilene, and I presently reside in New Braunfels. I'm a patient advocate and community outreach manager for the Global Healthy Living Foundation, a nonprofit organization whose mission is to improve the quality of life of people with chronic illness. I live with several chronic illnesses, but the one that impacts me the most is chronic migraine. For me, migraine attack is so much more than excruciating head pain. It's also decreased motor skills, nausea, sensitivity to light, sounds, and odors. For 2 years, I wasn't allowed to drive due to balance issues. When I finally found a specialty treatment that provided some relief, I was hopeful but nervous because it was so expensive. I could only afford this newer medication if I received patient assistance funds from a charitable program set up by a drug manufacturer. Unfortunately, the medicine that provided relief to me suddenly became more expensive because of a policy embedded into the fine print of my insurance contract, a copay commuter program. Copay accumulator programs prevent the money provided by charitable patient assistance programs from counting towards patient deductibles or out-of-pocket maximum. I expected my patient assistance funds for my migraine medication to be applied to my deductible, but they weren't. Unexpectedly, my monthly copay jumped from $40 to $350, as much as a car payment. At that time, I was classified as disabled and had lost my job. I had to make a hard decision about whether I could afford my medication. When my son was also diagnosed with migraine and needed expensive medications, I stopped taking my medication for a while to put his health ahead of mine. Like mine, his prescription was also slotted into the accumulator program. This was incredibly frustrating. Neither one of us should have to go without the medicine we needed to function, but I couldn't make the math work to pay for both of us. People with chronic disease are the ones at most risk for being victims of accumulator programs because we often rely on specialty brand medications for which there are no generic or biosimilar options, and we may only be potential effective treatment. To that end, patient assistance programs were created to benefit patients, not insurance companies. It's not fair for the insurance companies to accept these funds, use them up, and still expect the patients to keep paying their deductible. As it was mentioned, 16 states passed laws mandating that all payments made by patients funded by patient assistance programs or not count towards the patient out-of-pocket maximum or deductible. Texas can enact similar legislation to protect patients. Insurers oppose these kind of bills, claiming that if they become law, state insurance premiums will rise at a higher rate for everyone. However, new research from my organization, the Global Healthy Living Foundation, demonstrates that claim isn't true. Legislation that bans accumulator programs has not resulted in increases to state health insurance premiums beyond what has been seen in states without this legislation. In Texas and the United States, everyone should be able to access the medications that potentially will improve their health and ability to positively contribute to their family and community. Thank you for listening to my story today.
Thank you for your testimony. Members, are there any questions for the witness? If not, thank you for being here. This time, the chair calls up Jay Consiglia, Coalition of Texans with Disabilities and Self, testifying for the bill. I hope I didn't butcher that too bad.
It's all right, I'm used to it. Actually, you did great.
All right, you may proceed then.
I'm Jay Consiglia. I'm with the Coalition of Texans with Disabilities, and I'm speaking today for HB 999. I am a person with Crohn's disease and osteoporosis. I got Crohn's disease at 19, and because of my treatment for Crohn's disease, I ended up being diagnosed with osteoporosis at 32. For Crohn's disease, I have been relying on biologics to keep me in remission for the past 16 years. My biologic without copay assistance is $700 to $1,000 every infusion, depending on the facility I get it from. My osteoporosis medication, the copay for that is $500. So my medications without assistance cost more than my rent every month. And you know, these medications, extremely specialized. While there's a number of different Crohn's medications on the market, they're not interchangeable. The prevailing wisdom of IBD specialists and gastroenterologists is when you find a medication that works for your Crohn's disease, you stay on it until it doesn't work or you die. So, you know, if I no longer can afford to pay for my Inflectra, there are cheaper drugs on the market, but there's no guarantee that they'll even work. And while I'm in that experimental phase for a new drug, I may not be able to go back to Inflectra if I hit that inflection point and end up hospitalized, because when you get off a biologic, your body can start to produce antibodies to that particular drug. So I have to stay on it. And I have moderate to severe Crohn's disease, so if I'm not treated, I'm going to end up how I was when I initially was diagnosed, where I was in the hospital dying. I had 17 centimeters of ulcerated bowel and an abscess the size of a softball. So, you know, for me, I can't just not pay because I'll just end up back there with moderate to severe Crohn's disease. So, you know, I'm just a disability advocate for a living, so I don't make a whole lot of money. And I can't be essentially paying my rent plus double that every month and expect to be able to stay afloat. So copay accumulator programs are extremely detrimental to people, to myself, and then also people like me. So I'd really appreciate 999 continuing to gain traction and hopefully getting reported favorably from this committee.
Thank you. Let's see if there's any questions for you. Members, are there any questions? If not, good luck to you. Thank you for testifying today. This time the chair calls up Jamie Dudensing, Texas Association of Health Plans, testifying neutral. Is that correct? You may proceed, please.
Good morning. My name is Jamie Dudensing, and I'm the CEO of the Texas Association of Health Plans. I am neutral on House Bill 999. I just wanted to get up and say that we've really appreciated working with Representative Forprice. We do feel like the bill strikes a very good balance of addressing where the abuse happens around drug coupons, but still allows patients where this is a real issue to get the assistance and help they need. And I'm happy to ask any questions about how these programs work or what happens with coupons.
Yeah, let's see if there's any questions that we want to ask you. We will recognize Chairman Frank.
Yeah, whatever. Thank you, Chairman Harless. Thank you for being here. Can you walk me through, and I'm going to try to I want to do round math because it's easier, but you know, a drug that costs, say, $20,000 for the year, $5,000 max out of pocket. I've got a coupon. I'm trying to figure out where the pharmaceutical companies get in this. I know they have nonprofits that get set up, and I'm just trying to make sure we're not creating this big bird's nest for pharmaceutical companies to charge whatever they want, but also want to try to address the actual need of the patient as well.
So there have been quite a few reports and research done around where drug coupons are problematic versus where they're helpful. The coupons that we really are concerned about are the coupons that are targeted, that are only available for individuals that have health insurance. only during their deductible, not available to everyone else on this piece. And usually, and as the bill addresses, when they're done to target when there is a true generic available, where it is the exact same drug, but you're talking about a very high price. And in the studies around this, it shows that where drug companies spend $1 on the coupon, they receive $4 in profits. And so, like I said, the bill takes care of this, where competition, true competition exists, and there really is an issue around trying to hook someone on that higher price drug and then have that coupon disappear, and then the health insurer pay that premium, but that cost being passed on to other enrollees and employers through higher premiums. That's a problem. Where it's a consumer where there is no competition available, and that's where you're really talking about orphan drugs or drugs that have no competition, and that's where you see the highest price drugs.
Right.
This bill would protect patients in that situation.
Okay, thank you.
Thank you. Members, any other questions? If not, thank you for being here as always. At this time, the chair calls up Chase Bearden, Deputy Executive Director, Coalition for Texans with Disability and Self.
Thank you.
Thank you for being here, sir.
Appreciate it. Chase Bearden with Coalition of Texans with Disabilities, testifying for myself and CTD. We are for the bill. I want to thank Representative Price for all his work on this. HB 999 does affect a lot of our members specifically. And I'm not going to tell my side of the patient story. My wife has dealt with this. But what I do want to talk about is how the bill was structured and how we got here. There's been a lot of thought put into this bill, and words matter. So amendments that might be thrown or any idea, these things really have to be thought out because this is such a complicated deal, but it affects a lot of people. And I do want to address, Chairman Frank, some of the things you were asking about how the funding goes and employers. One thing, Jay, that came up right before Jamie, she's an employee of ours. She's been amazing, and I'm sure she wouldn't mind me sharing this. But when we went through the hiring process, one of the things I asked, being a disability organization, we have a lot of people that have a lot of chronic health issues, is what things do you really need? If you're going to move here from Houston to work for us, and I will admit her salary is not great, we work for a disability nonprofit, what is it you need? And we had a long discussion about our health insurance. I mean, this is something our organization realizes having healthy employees actually makes our business run better. It may cost a little more for us, but at the end of the day, having someone there who's healthy, not having flare-ups, not in the hospital, they're doing the job they need to do to be a paying citizen. And one thing we really have to watch is that when someone can't get their meds and they're dealing with a very significant chronic health issue, and they no longer can work because they've been having to play games and they've come off their meds and gone back on, they're not as effective. Who's going to pay for it after that? We are as the state. They're going to end up on Medicaid. So those that we can protect, those we can keep working, those that families are able to do what they need to do, not end up in medical debt so far because they're just trying to pay their deductible at the end of the beginning of the year. That's what we should be doing and putting that focus there. We do appreciate that health plans have gone neutral. I think that's because of a lot of work that's been done on this, and we're willing to work with everyone to make sure at the end of the day that it's about Texas patients. It's not about pharma. It's not about the insurance companies or the PBMs. It's about protecting Texas patients and letting them get on with their lives. And if y'all have any questions, we're more than happy to speak about this bill. It really does make a difference. I'd love to ask that each of y'all sign on with Representative Price today. No better day to sign on as a co-sponsor. We won't come by and harass you for any other thing.
Let's see if there's any questions for you. Members, are there any questions for the witness? If not, it's always great to see you. Thank you for being here, sir. Is there anyone else who wishes to testify on, for, or against House Bill 999? If not, the chair recognizes, I'm sorry?
My name is Shelley Clausen, and I am registered, but I did not plan on testifying. But I wanted to clarify some questions.
Okay, hang tight.
Did you say Shelley Clausen? Yes.
Okay, here we go. We have you registered as Shelley Clausen, Texas Bleeding Disorders Coalition, and yourself testifying for the bill. Is that correct?
Correct.
All right, you may proceed.
I just wanted to address a little bit more, Representative Frank, to your questioning about the process and how the coupon works. I have a 11-year-old son with severe hemophilia A. We don't actually hold a coupon. We don't actually submit a coupon. We submit every year to a copay assistance program. And then we're sent a letter in the mail that says you're approved or you're not approved. The way it works is when we place his refill or fill his prescription, which by the way is through a specialty pharmacy. We don't get to go to Walgreens or CVS. We have to get on the phone. We have to go through all the questions. What's your name? What's your address? Do we have permission to speak to you? And then we fill the prescription. For this year, our personal experience, we're good. For Melissa's son, you gave an example earlier about $20,000 a year. His medication is $30,000 a week. We are talking $350,000 a year for the cost of this medication for a bleeding disorder. So the patient never sees that reimbursement or that coupon. The coupon goes directly to the insurance. And then like others that have talked before me have said, they just add it to the bucket, but then also it doesn't go towards their deductible. So then in the first month of January, Melissa is getting a bill that says, we can't fill Kyle's prescription because we need you to pay your deductible of $10,000 or whatever that out-of-pocket is.
Thank you.
Thank you for your testimony.
Thank you.
Hold on, let's see if you got any questions. Members, are there any questions? If not, thank you for being here.
Thank you.
Now, is there anyone else who wishes to testify on, for, or against House Bill 999? If not, the chair recognizes Representative Price to close on the bill.
Thank you, Mr. Chairman. I'll make this very brief. In a very basic sense, the bill is intended to help the enrollees by indicating that it doesn't and shouldn't matter who's helping the insured pay the copay, whether it's assistance from a foundation, from a patient assistance program, from nonprofit. The fact is, it should count towards the copay or the out-of-pocket maximum that they are subject to. I do want to thank the health plans. I do want to thank the stakeholders and the advocates. This has been a 3-year process to get language crafted that strikes a very fair balance. And as you can tell, it really affects a very specific population, and this committee is charged with helping reduce the cost of health care, and I think that this will do that for a very specific population to a very significant degree. Again, I appreciate you allowing me to lay this bill out and would be happy to answer any questions. Other than that, I close.
Members, are there any questions for Representative Price? If not, if there's no objections, House Bill 999 will be left pending. Is there objections? The chair hears none. House Bill 999 is left pending. The chair moves that this committee stand in recess until final adjournment or recess of the House or during bill referral if permission is granted. Is there objections? Hearing none, the motion prevails. The committee stands in recess.